Now, what is the surgical options? The most commonly nowadays, the option is always the total hip arthroplasty. But again, depending upon what is the stage and whether we can go for some other form of options as well if it's pre-collapse stage as well. For example, there's other options such as hip resurfacing, vascularized fibular graft, non-vascularized fibular graft, use of bone grafts. All these can be an option as well. But depending upon the stage of disease, we have a FICARD classification for that. And once we have passed the stage of FICARD 2B, which is actually where this crescent sign becomes positive, which is actually increased subcondylar sclerosis and representing a lunar shaped sign called as crescent sign. Beyond that age, it's when the head starts to deform or it's completely deformed. That is the time where you have to go for total hip arthroplasty. Otherwise, we can go for some other form of a surgery as well. If the things are not improving with all those conservative measures such as NSAIDs, crutches, canes, as well as reducing the weight. If it's not working, then you have to go for total hip arthroplasty. So what is the total hip arthroplasty? If you see it, we actually usually we change the whole joint, the hip joint. Hip joint is formed from the acetabulum as well as the femoral head and neck. So what you do is once it has deformed, you cut the proximal femur, you give it a femoral cut and put the femoral component in, and then you ream the acetabulum, and once it's been properly reamed, then you put in the acetabular component. Now acetabular component could be metal backed, could be soft components such as polyethylene backed as well. And then we can have the similar, usually the femoral component is either metals in form of a titanium or in form of a cobalt or chrome. These mostly it's always the metal. Then again, it could be hard and soft articulation and soft articulation as well. Indications, when we're talking about total hip indication, the first and foremost is always the pain, debilitating pain, which actually has now resulted in the patient is unable to carry his or her activities of daily living. If the patient cannot carry out her daily living, despite in our patient was taking aerobic classes, was going to a chiropractor, was taking all sorts of treatment, but still was not relieved of pain. She was having disturbed sleep as well, and now the pain has become bad enough that it was affecting her life. That is the foremost indication, and that includes pain. That includes the level of disability, because it starts to affect your activities of daily living. There is loss of function, which may be coupled with disability or may be isolatedly present as well. There may be severe pain of movement. Pain on all sorts of form is always associated with total hip arthroplasty. There may be associated disturbed sleep due to pain, pain at rest, and functional limitations, reduced walking distance, and age. Now, if you imagine this, actually it's the pain which is hampering your life. If your life has been stopped by the pain, probably the first thing to go for is actually total hip arthroplasty. But why age is also a factor? Because what matters is usually if we perform total hip arthroplasty too early, let's suppose we are performing a total hip arthroplasty at the age of 30 or 35, then probably that would require a revision hip arthroplasty at the age of 45 to 50 years of age. So we have to keep that in mind as well, that the patient should be old enough, because once they cross 60, the level of activity slightly decreases. Therefore, this articulation can go up to 15 to 20 years. So probably even if they do require second surgery, that will be at the age of 75 to 80 years. So something we need to keep in mind as well, because with every subsequent surgery, it becomes more complicated. There is increased chances of complications with every second surgery. Therefore, when we are doing the primary total hip replacement, we have to bear in mind that it should be the best possible surgery you can give to the patient. Now, surgical approaches. As to the hip joint, there are multiple approaches can be done. It can be, usually it's always the surgeon's preference, whether he or she wants to do a direct anterior approach. There is a medial approach as well, then anterolateral approach, but usually medial and direct anterior is more reserved for the hip surgery of the children, especially in the case of developmental dysplasia of the hip. Other is usually we can go for this anterolateral approach, or we can go for direct lateral approach. This direct lateral approach is called as Hardinge approach. There is also the modified Hardinge approach as well, and we have the Watson-Jones approach in form of anterolateral approach. Other is posterior or Southern and Moore approach, which is actually the Koshel-Lagenbach approach is actually extension of Southern and Moore approach. Then again, it's no hard and fast rule how you should approach a patient. Again, it's a surgeon's preference. Usually some surgeons prefer posterior approach, some prefer anterolateral approach, others prefer usually transgluteal or direct lateral approach. Depending upon what is your preference, you can go for any of the approaches. Again, bearing approaches. What is important over here is that, as I told you, there's certain components of the femoral can be made up of metal, and other are made up of poly, which is called as high molecular weight polyethylene, which is actually, when you have a metal and poly articulation, this is one form is actually having a metal on metal articulation with intervened poly, or metal on poly articulation, in which the femoral component is of metal, but the acetabular component is of polyethylene, which is fixed in the acetabulum. Then it could be metal on metal, in which the acetabular as well as the femoral component is both made of metal with intervening polyethylene. Or it could be ceramic and ceramic, or ceramic and metal. This is when you have one of the component is made up of ceramic, others of metal, or when both the acetabular and femoral component are made up of ceramics. Or we can go for ceramic and polyethylene as well. But what is important to know is that all these articulations have usually certain advantages and disadvantages. For example, metal on poly has an advantage that it actually does not degenerate quickly, and it's a good option. But again, the problem is that once the poly actually thins out, and there is increased wear and osteolysis with it. For example, if you're doing ceramic and ceramic, the thinning out and wearing rate is far less. But the problem is you do not have a lot of sizes available as well, and sometimes you're actually stuck up in this because you do not have a different modular implants available for in case of ceramics on ceramics as well. So all these have their own positives and negatives associated with it, and one has to keep in mind that there is no such thing option as best option. Most surgeons prefer metal on metal and metal on poly articulation in case of hip joint. Now, implants type, as I told you, this could be one form could be cemented total hip arthroplasty, uncemented total hip arthroplasty. Whenever you are doing actually femoral component, you place the femoral component in the intramedullary cavity. One way is that you can snugly fit in without putting in a cement, and that becomes uncemented total hip arthroplasty. Or you can put in a cemented one along with putting some cement in the back of the acetabulum as well, and then this becomes a cemented total hip arthroplasty. Now, uncemented form you can have, there is other form is called as hybrid, in which one component uncemented and other is really cemented. This is most commonly acetabular component is cemented one, and you have femoral component which is morely uncemented. And third is hip resurfacing. In hip resurfacing, the only thing which we do is we replace the femoral head without replacing a femoral neck, as well as the acetabular component stays same, which is the native acetabulum, native neck. Only the femoral head is replaced. Now this is an X-ray which is showing cemented Charley cemented total hip. It was actually Sir John Charley which gave this idea of hip joint replacement, and his design was called as the Charley's design. That was the original design. You can appreciate this is a thin long stem with a very small head, and this is the poly, this is metal and poly articulation with cement being done into the you can appreciate it in the acetabulum as well as the femoral. You can see the cement mantle up there as well. At that time, the techniques which were developed is that they used to do the greater trochanteric osteotomy. They used to take it out, then they used to cut the proximal femur, put in the component, and reattach the greater trochanter in form of a cerclage wire as well. This was an initial technique which was later on modified by multiple others, and then we have now, this is one of the extra cemented total hip. If you see it over here, you can appreciate the cement. Now there is no osteotomy of the greater troch being done. We have different jigs and instruments which has actually over the period of time. This was in 50s and 60s. Now we are in 21st century, so we have developed a lot of other things as well along with it, and it has actually become more of a from initial Charley design. Different designs have been developed by Zimmer, Exeter, and other Johnson Johnson. Different companies have come up and they have developed their own designs actually. Now this is uncemented total hip. If you see it over here, you cannot appreciate any cement. The implant is snugly fit in, and this is actually the metal on metal. This is the metal articulation with intervening poly, leading to uncemented total hip arthroplasty. Now coming to the acetabular implants. Sometimes patient may have a problem with this sort of issue. You had some form pre-operative, there is a history of trauma, the patient develops anterior as well as posterior trauma leading to involvement of anterior wall as well as the posterior wall as well, and all this surgery and plating is being done. Now if you have to recreate the total hip over here, you cannot appreciate any head over here, and the hip is almost ankylosed. Sometimes you have to use certain instruments in which you may have to bring down a femur relator, in which you have to use some form of modular implants as well, and this can lead to, now there are different variety of modular implants are also available, which can be available in form of uncemented as well as cemented form as well. Now uncemented femoral stems, when we are doing it, usually have newer generation of femoral stems have certain pores over on the top of it, in which there is actually bone ingrowth, and this bone ingrowth leads to a stable bond between the metallic implant and the bone, and therefore you don't need a cement in it. For example, this holes was actually there if you need to do an osteotomy in the greater troch. These holes are for the passing of cerclage wire, but if you see there, the stem is snugly fit in, and it has actually, the structure of the stem is such that there is actually a possibility of bone ingrowth, and once over the time the bone ingrows, this actually the implant is highly stable and it does not need any cement over there to be completely fixed. But in cemented case, you need cement to actually stabilize the implant, and later on the bone cement interface is actually the main bonding force rather than bone implant interface. Now hip resurfacing, as I told you, this is what actually happens. Only the femoral head is replaced, and this it's called as implant is actually fixed into the femoral neck. The patient has the native acetabulum, the patient has native neck, but only the femoral head is replaced. Nowadays hip resurfacing is actually being phased out. There is very small few indications for hip resurfacing, especially when you do not have any neck fracture, or especially only associated head fracture is there. But if there is acetabular arthritis or if there is neck fracture, then you probably hip surfacing is not an option, because the patient will not be relieved of pain. Pain would still be there due to the acetabular arthritis. Therefore, in that case, you probably will have to go for some form of a total hip replacement.